generate the different cell types that are found in the brain from a single clonal cell. So here we have a culture that I put down from a mouse tissue, and we have two types of glial cells that grow out, the support cells, and a cluster of neurons here projecting their axons out onto this glial tuft. Also, if I was to inject this adult mouse, with a tracer that we came up with in our group, which I'll speak about later, we can show that there is neurogenesis in the adult brain, especially if we trigger neurogenesis, and that these cells go on to form mature neurons and integrate into existing circuits. So this kind of discovery has generated a huge amount of studies within the medical research areas. And these are just some of the studies I have been involved in, all the way through from specific genetic disorders, all the way through to aging brain, and now more recently cancer cell proliferation in the human brain. And these were done with a whole load of collaborators stemming from Adelaide, down south in Australia, to Oxford in the UK. So I'll try and break up my talk into these sections. Cell therapy, these are not actually stem cells, the glial cells, they're mature cell types, but they are very, very promising therapeutic option. Then I will speak about my work on embryonic stem cells, which I did as my first or second postdoc, and then my work within the adult stem cell area. Right at the end, I will speak to you about some of the work I have been involved with regards to cancer. Though we call it stem cells, the proliferative cells within cancer. Okay, so glial cells. This is where my current employer is, Griffith University. I was drawn to their laboratory because they were the first group in Australia to use adult stem cells in autologous therapy in the human subject. So this was a very, very small study, primarily to show that this particular type of therapy does not cause any more damage to the subject. And this is, of course, using the human olfactory ensheathing cell, which is a type of glia. This paper was published in 2005, after 1 year since the start of the study, and published in Brain. As I mentioned, the feasibility and safety were the primary concerns of this study. These cells were taken from the olfactory, which is a neural mucosa, from the olfactory epithelium, neuroepithelium, of the subjects themselves, grown up in culture, and re-injected back into the spinal cord lesion in these subjects. And the lesion had occurred 6 to 32 months previous to the treatment, so it's not an acute injury. These are some MR images of these three subjects. This is pre-surgery, and this is 12 months post-surgery. Data from all three subjects showed that there was no further damage to the spinal cord after the actual grafting. Now this shows how conservative the approaches are in Australia. I can't speak for China, but certainly in the medical research area in Australia, they're extremely cautious about how they go about testing potential therapies, certainly even at a phase 1 clinical trial. Great thing is now this study has set the pace for future work, and there are several phase 2 trials going on now with much larger patient cohorts looking at subtle differences in this type of therapy. Okay. So I will move on to the embryonic stem cells. I'll come back to some spinal cord work again, but in the embryonic stem cell field, my second postdoc, it was about treating Parkinson's disease, which is a degenerative disorder rather than an acute lesion. Um, we use both human and mouse embryonic stem cells and tested our platform technology, which was really a conditioning medium for embryonic stem cells that neuralized them. We had a fairly substantial amount of funding coming in from the government, and more importantly, we had access to 4 NIH-listed human embryonic stem cell lines, which we could work on. Very brief overview of Parkinson's disease. It's a severe neurological disorder, and there is increasing prevalence worldwide. It is the motor symptoms of it is due to the death of dopaminergic neurons in the substantia nigra, which is an area of the brain that produces dopamine, which results in disturbances of motor posture and movement. In the normally functioning substantia nigra, the nigral neurons project forward rostrally into the striatum, or caudate putamen, and release dopamine. So, in our animal models, what we aimed to do was to lesion the substantia nigra unilaterally, and then replace that dopamine source within the striatum itself. Okay, so these are some of the images from our experimentation. We grew up our cells and caused them to neuralize, as you can see here, what is called the neuroectoderm, forming around these cultures. We seeded them down, just like in that previous image that I showed you. There's a whole layer of glial cells there, and then the neurons projecting the axons out into it. We showed that they express the relevant protein markers of mature neurons, here beta-3-tubulin and neurofilament 200 structural protein. And we showed that if we were to graft in these cells into animal models, that they survived and differentiated into neurons. Okay. What we made sure that we did right through our experimentation was to use a good positive control. These mouse ventral mesencephalon cells are the cells that give rise to dopaminergic cells. And we ran parallel controls every time we ran an experimental run. Okay, so here's our model. Unilaterally lesioned using 6-hydroxydopamine, a neurotoxin specific for dopaminergic neurons, injected unilaterally, of course, into the median forebrain bundle, which is the axons that project out of the nigra into the striatum. It killed all the dopaminergic cells within the nigra and also denervated the striatum. So there was no dopamine release within the striatum. Then what we did was go in and inject in a variety of different types of these embryonic stem cells into the striatum. And my main role was to try and analyze them anatomically as accurately as possible. So as you can see, dopamine synthesizing neurons identified using tyrosine hydroxylase, which is a rate-limiting enzyme of dopamine synthesis. They survived well in these animal models. What my group also did was to do the behavioral testing. So we used the amphetamine challenge, which caused the release of dopamine from these cells, and it reversed the motor symptoms in these animal models. We did these tests for 6 and 8 weeks post-grafting. Now, here's data from the mouse ventral mesencephalon grafts. What you can see are mouse cells within the racked striatum, identified using a DNA sequence that's very specific for mouse cells, and therefore we can identify this cell as being a mouse cell. And what you can see here is beautiful engraftment. They are showing typical mature dopaminergic neuron-like morphology. This is a graft, in fact the best graft, of human embryonic stem cells that were neuralized and grafted into this animal model. And what you see are very few neurons amongst a cluster of human cells, once again identified using a fluorescence in situ hybridization against a human-specific DNA sequence. Very few dopaminergic neurons. Now, what I've done is right through this presentation provided lots of references that you can go to and refer if you all are interested in finding out more about these studies. All right. So here's our positive control. What we show is that these dopaminergic cells also express vesicular monoamine transporter, essential for the function of the dopaminergic cells. And they also express synaptophysin. What you can see here is the synaptophysin in red, co-localized within these dopaminergic cells, which shows that they are synaptically connected as well. When we looked at the human embryonic stem cell graph, there were beautifully grafted cells. Some of them express glial marker proteins, and here in the merged image, quite obvious. They also showed they expressed nestin, which is a precursor marker for neurons. And if you looked at this graph site carefully, you can see a huge amount of heterogeneity. So while one part of the graph expressed nestin, this precursor marker, a lot of the other sections did not express this. And what we did find was a lot of teratoma formation. So with regards to recapping ESL therapy for Parkinson's disease, well, together with this anatomical work, we also looked at gene expression profiles using qPCR, membrane properties using electrophysiological techniques to look for neuron-like properties in these cells. We looked for dopamine and serotonin release from these cells using HPLC, and also a lot of other cell surface markers that were critical for us to validate our data. Despite all of this, and despite extensive manipulation of the embryonic stem cells in culture, what we found was recurrent teratoma. We could not eliminate differentiation or transdifferentiation of these cells back into a pluripotent cell type. There was also very limited dopamine cell survival and limited functional recovery of our animal model, though we showed really robust recovery using the ventral median positive control. Now, all this sounds very depressing, but we did make really good headway. We published extensively in this period of 2 years, and it also gave us opportunity, as in this case, we used mesenchymal stem cells much later in the same model using the same test, and tested it very robustly as to whether this is a treatment option as well. And more reassuringly, that we didn't fail in our attempts. Anders Bjorklund, who's a real godfather of embryonic stem cells and Parkinson's therapy, in 2013 made this statement on embryonic stem cells and Parkinson's therapy. This will take some time, as we have to understand the biology of stem cells and what guides repair in the brain. Now, this is a critical point. Okay, besides those previous studies that I mentioned, this particular area of work has generated more recently a lot of other data sets that we have published. This was published by one of my PhD students, a Tau article for Brain, where he generated a really nice model of Parkinson's disease, where we showed a recapitulation of the degeneration that you see in Parkinson's and the activation of glia, which we believe now play a major role in the progression of the disorder. We've used genetic models in this kind of experimentation, looked at protein aggregation in these neurons, and also developed the models, as I mentioned earlier. To actually succeed in this work, we had to really go back and make sure that our neuroanatomy was absolutely spot on. This is a section through a dopaminergic cell, 0.2 microns thick. And what you can see, I hope, what you will see within this 0.2 micron area, I've lost the mouse now. I'm used to a laser pointer, I'm sorry. Okay, here you go. Okay, so a very, very fine glial process in close opposition to this cell. And we are able to quantify this. And when we quantify it using computerized algorithms, which are completely unbiased. Similarly, if you were to take a single section through a 0.2 micron section through one of these neurons, we can actually show quantitatively overexpression of markers such as, in this case, superoxide dismutase, which is a stress granule marker. These cells are undergoing apoptosis. We can quantify that very accurately, once again using computerized analysis techniques. Let's hope this works. All right, here we go. So that jumped ahead, but it doesn't matter. This is astrocyte using our sectioning techniques. Not showing the whole cell, but it doesn't matter. This astrocyte is actually surrounding a blood vessel, and these nuclei are nuclei of endothelial cells that are located within this blood vessel. So this is microscopy, not confocal or something super fantastic. It's conventional microscope with an instrument called the apotome fitted onto it. And it gives this level of resolution, where we can pick up single fluorescence in situ hybridization fish particles within the nuclei of endothelial cells within a blood capillary surrounded by a single astrocyte. And we can quantify all this information automatically, which is really quite powerful, unlike poor Ramon Cajal, who had to sit down and count things manually. So we can move on. It won't interfere. Run its course. Okay, how do I get that? Okay, thank you. All right. These are all embedded files, but we had some difficulties just now. Okay, we are not moving forward again on this presentation. Okay, great. All right. So anatomy of neurons. This is a substantia nigra pars reticula neuron. Turn both on at the same time. Yeah, okay. What we use this 3D data, where we can show fine anatomy of single neurons, was to classify them, so that we could investigate them individually as to whether they were more susceptible to the disease progression or not than compared to another neuronal type. So these are compactor neuron, very small cell body, processors emerging from the different planes of the cell. And this is a reticular neuron, which lives right adjacent to the compactor neurons. It's the largest spindle-shaped cell with the processors emerging from the two poles of the cell. And what we did find was that the compactor neurons were more susceptible in our model than the reticular neurons. So when we approach therapy, we can go in with a bit more information. Not just those pretty pictures, but we applied this technique to some of our work on spinal cord injury. And this is a hemitransected spinal cord that we generated in mice. Can I get the cursor back again? I wish I had a laser pointer. I could go through much faster. Okay, there we are. And what we did was use a scaffold, and within this scaffold we embedded neurotrophins. And what you can see here is that it encouraged axons to regenerate across this lesion site, even though it was quite separated. And this is our control animal, where we had no scaffold. In fact, we put in the scaffold, but not the neurotrophins in this case. We can generate statistically significant data, which is quite robust. So we can publish this work well and progress on to the next phase. We did similar kind of analysis in peripheral nerve injury. In this case, it is a sciatic nerve, section through one, showing profile of all the axons. And we generated about 600 to 800, I think it was, yeah, between 6 and 800 images like this. And to have counted all of these profiles manually would have been a nightmare. It would have taken us months. But the computer did this for us in about 30 minutes. So this shows the power of embedding computing within something like a neurosciences program. So if you all have strong computing capability, like our gentleman over here, I would strongly encourage you all to use those skills when you all go into your research areas. And I've got chemists embedded within my research program as well, and I'll talk to you about that. And certainly some heavy mathematics here. It's no point generating good numerical data unless you can analyze it properly. And this is using a technique called stereology. So if you all are mathematically oriented, there is definitely scope for you all within neurosciences, so that we can present our data so that it's irrefutable. These quantifying absolute cell numbers within the brain. We also reward our computer scientists by allowing them to play a bit. And here, my ICT student went on to use our data to generate neural network algorithms, self-learning programs that were able to tell us what is a disease cell and what is am I running out of time here? I'm taking it rather slow. Okay. Can we turn this one on? Give you a bit of respite from my monotone. So this was a... I'll let it play. It's national TV in Australia. Okay, this is a bit of light relief. He's IT student and his neuroscience is not that accurate, but that's okay. he he gave the message quite well. So let's get on to adult neural stem cells. So we spent some time on embryonic stem cells and techniques. Adult neural stem cells, my main interest in that area was the potential for autologous therapy. Because a lot of the problems that we encountered with embryonic stem cells was tissue rejection, cell rejection. So when we go into adult stem cells, what we find is a very, very heterogeneous tissue, especially in the case of the neuroepithelium, olfactory neuroepithelium. These are sensory neurons within the olfactory neuroepithelium which are constantly regenerated because they are exposed to the external environment. Now these cells, when they die back, are regenerated from a set of stem cells that lie at the basal lamina of this tissue. When they regenerate, they reform the axons. These axons form bundles that then run up through an area called the cribriform plate and up into the brain, and they terminate within the rostralmost end of the brain in an area called the olfactory bulb. And when they innervate the olfactory bulb, they form synapses with a group of cells called periglomerular cells. Now, okay, can we play the sensory neuron anatomy? Brilliant. So this is the probe that I was talking to you about, where we could insert this probe into newly formed DNA so that we can track the daughter cells that are generated from cell division within the nervous system. And now I've taken it through to cancer as well. But what it does is it, without any form of error, we can identify these cells that were newly generated. Because this probe is a thymidine analog, and it pulls the DNA synthesis mechanisms to insert it instead of thymidine into the DNA, the newly formed DNA. And we can track those cells very, very effectively. And this is the anatomy component of it. We can then take out the tissue, section it, and identify zones of cell genesis. So we can identify very accurately our stem cell niches. All right. So that manuscript too, where we actually showed efficacy of that probe, had a very high impact within the scientific community. But more interestingly, what really drew me to this olfactory neuroepithelium was that it was a nexus between two zones of neurogenesis. One, in the olfactory neuroepithelium, but also when these axons project into the brain and they terminate in the olfactory bulb, they synapse, as I mentioned, with the periglomerular cells. Now, as I mentioned previously as well, these olfactory sensory neurons apoptose. They are constantly regenerated, which means that their synaptic input to these periglomerular cells die, which means that these postsynaptic neurons also undergo apoptosis. Now, this area of work hasn't been investigated much at all. So what I did was, in a mouse model, I lesioned these olfactory sensory neurons not once, but twice in succession, which meant that the input to the olfactory bulb was completely denervated for a period of about 14 days, which resulted in all those periglomerular neurons that received synaptic input for them all to die back, right? And what then we saw was a massive pulse of neurogenesis within the adult mouse brain, deep within the brain, in an area called the subventricular zone. It's known to be a neurogenic zone, but it has not been triggered before. And what we managed to do was to actually cause a large proliferation of cells, which then migrated into the olfactory bulb and differentiated into the periglomerular neuron population. And what is really interesting for us also was that this particular class of interneurons, they are dopaminergic. So we can actually study dopaminergic cell genesis in the adult brain using this technique. Now, together with this anatomy, what we have managed to do is to actually isolate these cells as well. We can isolate them and put them into culture and study them very extensively in culture because we can control the environment. This is another. We can study their physiology. Now, this is a dorsal root or sensory ganglion neuron, which we seeded as a neuroblast. It projected its axon to another cell, and it's communicating with it, and we can study that kind of interaction. So the physiology of these cells very accurately too. Right. Should I can't find my mouse again. Okay. Yeah. Okay, brilliant. So we can study these cells in detailed anatomical studies. We can look at their physiology in culture. But what was missing was a study of their genetics. And my most recent work involved dissociating these adult tissues once they were labeled with this proliferation marker, and then separating these cells out for genetic analysis. And we succeeded in doing that, and what we did was then say, okay, what's the next most important tissue that undergoes proliferation that we would like to get a handle on, and this was cancer. And I turned to some of my collaborators in the UK to look at glioblastoma multiforme. And these tumors are very, very aggressive. From diagnosis, it takes just over a year usually before the patient succumbs to this disorder, this disease. But like Dr. Ranasinghe said, these guys undergo regular decompression surgeries because otherwise there are secondary effects of this tumor growth. So we used to collect the tumor from these subjects as it comes out of the theater, put some of it into culture, and as you can see, characterize them quite strongly in culture. But also bring them back or take them to Australia, where we would graft them into immunocompromised mice and regrow the glioblastoma multiforme in the mouse model. And we could then inject these mice with the proliferation marker, isolate these cells, and characterize them fully. So, together with our adult neuroepithelium and subventricular zone work, the glioblastoma cells could be isolated using this technique called fluorescence-activated cell sorting, where we could get about 1 million cells that were undergoing proliferation from one of those tumors in a mouse brain. They are primary human glioblastoma multiforme, of course. And we can get really good quality RNA out of them. And what we can do then is to characterize those proliferating cells within these tumors. This is actually a mouse astrocyte invading the transplanted tumor, and they are undergoing division as they are co-localizing this probe called EDU. And these are microglial cells that are invading the tumor and also undergoing proliferation. But with our techniques, what we can do is isolate just the glioma proliferating cells and subject them to a full transcriptomic analysis. This is just a very, very small data set from that, showing very elevated CD44, which is a marker protein for glioblastoma, highly elevated in these EDU positive cells, which is cells undergoing division in the glioblastoma form. We validated all of this data using a proliferation marker called Ki67. Once again, we have generated a few papers from this work, but more importantly, we've just submitted into Nature Methods this technology that we've developed to study the proliferating cells in both the adult stem cells as well as the proliferating cells in glioma. So that kind of brings me to the end, much to your relief, I'm sure. Stem cell therapy will treat traumatic CNS injury or even peripheral nerve injury. And the question is when? Well, like one of our previous speakers, I think that's really up to you guys, because I do need, for a lot of the future work, clinicians, people who are involved in clinical work, to engage as academics and to do some of this research, because we do need deep clinical insights to the future of this work. Thank you very much. I'm happy to take any questions now.
Thank you, Dr. Medenia. I would like to invite Dr. Kitsiri Edrisinghe, Deputy Chairman of IIHS, to give a token of appreciation to Dr. Adrian Medenia for taking part in the conference today. Thank you very much for all your contributions, sir. So I would like to invite Dr. Kitsiri Edrisinghe to speak a few words about the story behind BioInquirer 2014 Trauma and Emergency Care Conference.
Hi, good evening to everybody. We are hoping go for the tea now. Just I take 2 minutes of your time. Just to brief you how we have gathered this wonderful conference today, yesterday and today. Well, this happened, I think, last year once we did the November conference. We were trying to figure out a topic to do. And then Dr. Nishan Disilla, who is always advising and working with us, came up with an idea of trauma. See, when you do good things, automatically things will come into place. Then next week, Dr. Nihal met me, and Dr. Nihal just mentioned that Dr. Leonard Johnson is going to visit Sri Lanka. So that came to another level, because Dr. Leonard Johnson is a trauma surgeon. So from there onwards, we just pushed him and pressurized Dr. Rana Singh a little bit in indirect way through Dr. Nihal to visit Sri Lanka, which was long pending visit, mind you. We were expecting you for the last almost 2 to 3 years. Thank you very much, sir, for your presence and your contribution. From there onwards, then we looked at, we worked on the whole conference from January onwards. And then our friend in Coventry University, David visited us. David Dashwal, he's a director international, he's a very good friend of ours. Very great support of Sri Lankan education. Then I just mentioned to him whether we could look into this. Immediately put into the Mr. Tim's boss, Dr. Dr. Philip Scullion. He's the head of nursing department in Coventry University. Then immediately appointed Mr. Tim. So thank you very much, Mr. Tim, your presence. And then parallelly, then Dr. Leonard Johnson was interested. And then he slowly asked us whether it's possible to get Dr. Gaza. And we were very delighted to hear that. Of course, with his support, he's here. Thank you very much, Dr. Gazin, and coming all the way. I know you have a very busy schedule, and you have to cut down one of your trips to Bangladesh, I suppose. Oh, yeah. So he has to, with all his work, we are grateful to have you here. Then parallelly, then we had this Australia Education Conference, and then I happened to be there by the Australian High Commissioner about 3 months ago. And then I happened to meet this gentleman, and we were having a chat for about almost half an hour. At the end of the half an hour, he gave me his card, and then I asked him, which school did you go to? Then he said, St. Thomas's. Then I looked at this thing and said, are you Medeni? We used to call him Mia in the school. He happened to be my classmate. I met him after 35 years, I suppose. Maybe 30 years, 35 years. So then it happened to be, he told me that he's doing work on stem cells. So that puzzle, that small piece also came to the picture. Then of course, always Open Institute of Malaysia, we are a learning center, IIHS of Open Institute of Malaysia, and Dr. Farida Binti Hassan, she's a professor, and she's the head of the Department of Nursing Faculty in OUM. I just dropped an email to her. Then she also told us it's a great area, and we have an expert in emergency and especially paramedic medicine. And she appointed Mr. Ramesh here. So with all that, then Dr. Nishan brought Dr. Samita to our IIHS Pandit to speak to the students. Then, of course, we convinced her to join us as well. So parallelly, all these things slowly but surely got into place. And of course, Dr. Nihar, as always, has been helping us and directing us, advising us for this function. So, see, these things will happen. Also, you have to have the intention of doing things. And we managed to get the government sector, the private sector, and also the nurses, physiotherapists, and some medical administrators. All are with us now. I think this should go on. The next step has to be more collaboration, more global platform to share our knowledge and skills. Mr. Tim is very, very interested in doing some work through online exchanging our ideas and sharing lectures, etc., etc. So this is just the beginning. It's up to the mainly audience, your audience. As professionals, we can just direct you. You have to take the baton and run and keep communicating with these people. But I've seen in Sri Lanka, we just meet people, that's it. It goes to your Facebook. But you should go more than that. You should communicate with them. Let's please write down these email addresses. We'll start with the top one is mine. Then the Surini, she was acted as a coordinator. And we have this BioInquirer website. There's the email as well. So we will direct the emails to relevant people when you have questions. Sometimes these professionals might not be able to answer you. So let's coordinate it through us, where we will having a separate department for this year onwards. And then let's move forward for the next event. So thank you very much for your participation. Thank you.
Thank you, sir. This message is for all the participants. I'm sure all of you have received the feedback form. Please be kind enough to fill it and give it to IIHS officials at the registration desk. And let's enjoy a cup of tea and come back after 15 minutes. Thank you.
She said, and this was in the actual article, she said, "I believe Paul would still be alive today if he had received immediate trauma counselling. Paul and I were made to walk the length of the hospital with a nurse carrying our dead child, watching as other mothers went by with their pushchairs. Then we were ushered out without any proper help or advice. That's when I knew there was a major gap in the system, with nobody taking responsibility for bereavement support." This was her quote. "The current bereavement system in the NHS fails to offer any aftercare, particularly for grieving fathers." In February last year, baby George suffered from a fit and he was playing at a family home in Miskin near Cardiff. He was taken to hospital, but he died hours later. Doctors discovered that the fit was brought on by influenza and bronchial pneumonia, which had not been diagnosed. In the following days, the devastated couple started to plan George's funeral and talked of taking their other 2 children on holiday to Lapland. Mrs. Burke said, "One minute we were all a normal family, getting on with life. Next minute it was all over. Paul took the car for a drive and I didn't think any more of it." And these are the, on your right, that's a husband and the baby George, and that's Rianne Burke. So a traumatic event then. Every clinician, being whatever your role is within managing trauma, will always offer the best level of care to those that are physically injured. They'll always try their best. Whilst we pay attention to the physical elements of care, we have a mnemonic to lead us through the assessment, clearly careful attention should be paid to both the psychological and behavioural aspects of the care as well. Now, the characteristics common to a traumatic situation are these: an emotional reaction to a difficult event, the loss of the ability to function, feeling of being overwhelmed, the situation exceeds the coping levels that individuals actually have. Let's go back. And I use an example here of a situation whereby I stopped at a road accident to assist. It was a young lad who had lost control of his vehicle and he'd hit a tree. The side of the car had been pushed in, so the middle bar of the car was sat next to his left shoulder, and he was still in the driver's seat, going in and out of consciousness. And I noticed that there was a colleague of mine from when I worked in the hospital who was indeed a nurse. What I noticed from her, though, is that she was running around not really knowing what to do, which is interesting because she was shocked as to what she'd seen. So in that situation, I thought it best to give her a job, and then it gives her some sense of direction and some purpose, and she won't lose that ability to function. So I just said, "Please, can you just control the traffic so we can start dealing with this young chap?" And it was because I think she was put outside of her normal coping situation. So characteristics of when you are exposed to a traumatic event include if you've had a previous exposure to trauma. So sometimes if you've been exposed to something that's been very traumatic and it's played on your mind, being exposed to something again may have a significant effect upon you. It does depend on your support systems you have, though. I'm a personal tutor for a number of student nurses, and there have been occasions where student nurses have actually experienced traumatic situations. So I've asked them, well, who do you have at home to talk to? Parents or any partners? And occasionally you get told there's no point talking to them because they don't understand. So it is about the support systems that you may have should you experience such an event. Clearly, there's issues around cultural responses and expectations as well. I do know that, for example, we have quite a large Irish population within the town I live, and they are quite a stoic sort of harder, perhaps, culture, where there are other cultures who respond in a very, very different way. We find Hispanics and Chinese become particularly emotional because it's their cultural background. Of course, it's the way you cope individually as well. So if you're not very good at coping in these situations, then it is clearly going to affect you. And of course, it's what defence mechanisms you have to control your own stress. Some people get exceptionally stressed and can't cope with it particularly well. Others seem to do very well. So what about then the sort of response you're expecting should somebody witness a traumatic event? Well, they can respond by a number of different ways, and from your perspective, particularly from a nursing side of things, or indeed or as doctor, it's anticipating what these responses might be. For example, you're stoically accepting. So if they were to witness something, and they just, that's just the way things happen. Or they could demonstrate significant anger about what's happened, or indeed become violent, or become exceptionally tearful and also hysterical. And I've seen all of these different situations and responses, having worked within an emergency department. There's one, though, that comes to my mind, was a youngish chap who was late 20s. Was probably twice the height of me, to be fair, and indeed twice the width. And the rugby team was short. So he asked his dad to play rugby. Well, his dad was an ex-rugby player, so his dad willingly said, I'd love to join the team. So they had their game of rugby. But unfortunately, his dad had a myocardial infarction, had a heart attack, and then went into cardiac arrest. And he didn't survive. So when they came to A&E, of course, the son blamed himself. So I took him into a room to break the bad news. I always sit nearer the door than furthest away from the door, because you never know how people are going to respond. So this guy stood up and he punched the wall. In fact, he put a hole through the wall, and I was quite pleased I was not on the receiving end. But I was near the door, so I could have made a run for it if need be. And it was an exceptional violent outburst. Now, I half anticipated something like that coming. So when you're assessing your patients initially, certainly within trauma, and not only from a nurse or doctor perspective, but indeed also from a paramedical perspective, that if we're going to move towards secondary assessment, there's a few things I think you need to consider. Well, when you're taking the history, for example, ask them about the recollection of the events. What do they remember about what's happened as the patient? But watch their reactions as well. Watch how, when they're describing the event, as to how they may respond. What you've got to think about, though, is think about the resources that you might need later on that might help to manage those effects. If they respond significantly to this trauma, what are you going to need to help you? Just like it may be if somebody has a fracture, what are you going to need to manage it? What about the physical signs? What can we look for physically? Well, when you're performing your head-to-toe examination, your secondary assessment, the signs might vary, because one of the problems with a physical assessment is that whilst we may see increased heart rate, increased respiratory rate, the patient may be nauseous or indeed sick, they could be sweaty, diaphoresis, they could be trembling or feeling apprehensive. These are all signs of things we see with patients when they become hypovolemic. So the response to the actual trauma psychologically could be difficult. In fact, I had a friend of mine who had all these symptoms and was always apprehensive, and actually at times found it very difficult to cope with things. In fact, he was assessed over a couple of years by various doctors and indeed psychiatrists, and he was diagnosed as being schizophrenic. However, he developed an abdominal problem, so he had an ultrasound scan, and they found a tumour on his adrenal gland. They call it a pheochromocytoma. But the tumour on his adrenal gland was producing so much adrenaline, that is why he was displaying all these what appeared to be psychological effects. Indeed, he's no longer schizophrenic because he had the tumour removed and all is well. So when we're looking for physical signs, just think about there could be other causes too. But of course, there are some other key things to look for. Repeating the same story or the same questions, asking you what's happened, being quiet or indeed not being able to concentrate properly. There's the emotional side of things we need to assess as well, because that's all part of our holistic assessment. And we're looking for anger and disbelief, may not be wanting to be left alone, being fearful. So these are all things that you need to look for when you're performing your secondary assessment. What are the costs? What are the costs of somebody experiencing a traumatic event? Well, in the UK, there's been no study that I've found that actually has discussed or looked at prevalence of traumatic stress. We're going to assume it's about 1.5% of the population at any one time. And that's because it's drawn on data from both American and Australian studies. We're similar in culture, etc., and so we'll assume it's about 1.5%. Now we know that following a traumatic event, most people will recover within 6 to 12 months. That just depends. However, there's 1/3 of all of those experiencing that trauma who will remain symptomatic for 3 years or more. That's quite significant. Of course, within the UK, there's another problem, and that's access to support. That's access to a clinical psychologist to seek professional help. Now, our GPs have great trouble trying to make referrals because there are so few of these people. 79% of GPs, in a study that was published within the guidelines for post-traumatic stress, experienced at least a 6-month wait before they could get their patient who'd suffered an event, traumatic event, to actually see a clinical psychologist. In fact, 22% of GPs had to wait 12 months. It doesn't match up, does it? It's a couple of days that George's father experienced. So in America, because we've got data on those costs, they say, and there's a website which is to do with post-traumatic stress, that 70% of adults will experience a traumatic event at least once in their lifetime. And that's quite significant. They actually say that 20% of them will actually develop post-traumatic stress disorder. Diagnosis for post-traumatic stress disorder, by the way, is relatively new as a diagnosis. I think this is alarming that the organisation actually stated that 8% of the American population have post-traumatic stress disorder at any given time. And I think that's a significant part of the population. The other thing, sorry ladies, but the other thing is that women are more likely, according to their data, to develop post-traumatic stress than men. However, in any event, an emotional trauma has really got three bits to it. It's got three components. An emotional trauma is it was totally unexpected. It wasn't planned, it happened, and we didn't expect it at all. The individual was actually totally unprepared for it as well. Wasn't going to expect it to happen. And the other thing, which I think is difficult, is that they couldn't do anything about stopping that incident. So, in terms of response event, it's unpredictable. You can't measure it. And what is useful is just to think a little bit about the physiology of the parts of the brain that are affected. So three main areas in the brain that are affected, certainly the cortex, where your higher thinking skills arise. You've got the middle part of the brain called the limbic system, where your emotions evolve, and indeed part of something called the amygdala. And the brain stem, and this is where all those basic transmissions are actually initiated from. So there's quite a lot of brain involved in dealing with this traumatic event. So what's the difference then? What's the difference between traumatic stress and post-traumatic stress disorder? Well, traumatic stress is defined as an event which goes beyond the normal range of experiences. So it's something you wouldn't normally expect. Now, we know most adults are resilient and may cope, and there may not be any psychological aftermath. There are things that you don't forget, but it doesn't sort of play on your everyday life. Whereas post-traumatic stress disorder is a term which is used to cluster symptoms together, whereby the experience could be experienced for a month or more after the event. So it plays and interferes with everyday life. And this is what I'm surprised with, because up until 1994, there wasn't a true diagnosis for post-traumatic stress disorder. It was the wars and the armed conflicts in things like Iraq, the Americans particularly, that actually did drive a diagnosis being recognised. And this is what they say. It's being exposed to a traumatic event in which a person experienced, witnessed, or was confronted with an event or events that involve death or threaten death or serious injury, or a threat to physical integrity of self or others. It's to do with the person's response involved in intense fear, helplessness or horror. So that was 1994, so quite recent as a diagnosis. However, there are other criteria that apply as well in terms of diagnosis. It has got to affect their daily life, it could be intrusive. The individual may avoid situations which may mimic or mirror what they experienced. And if they are to see something that's very similar to that event, it starts arousing a whole load of emotions again relating to that event. Diagnostically, it should cause some sort of occupational or social impairments. In other words, it does affect their general life day to day. So what's the likelihood then of developing post-traumatic stress and in terms of the incident? a number of years ago now, it's 30 years ago or so, there was an air crash in the middle of England. All died, and they diagnosed at the time that 40% of people that were involved were diagnosed as having post-traumatic stress disorder. However, another study looked at a sample of 188 road traffic collision victims, and only 10% of them were diagnosed as having post-traumatic stress disorder. So it's very much to do with the event itself, how significant that event was. Our other problem, of course, is that recognising it in children is really difficult. So again, that's just something to be borne in mind. So how do you recognise it? Well, symptoms are normally as follows. They may re-experience the event, and indeed they'll try and avoid anything that's similar to that event. They may have increased emotional response, or indeed emotional numbing to that event. May even appear depressed. They may turn to alcohol or drug misuse to help to cope with the event. They may be angry about it. Or they may have some unexplained physical symptoms. So it may be where they're attending and seeing a doctor or a nurse for things that may be totally unrelated, but they just may want to talk to you about that event. So it's not really clear about symptoms that actually do relate to a particular event, other than they may have flashbacks. Now, for children, because it's hard to diagnose, it's about asking the child, but take care not to rely upon the parental response, because you also have to be guarded about non-accidental injury. But do ask the parents, though, if the child's got any sleep problems, or they're irritable, if they have difficulty concentrating at school, in terms of school reports. So, in a traumatic event, then, there are 3 stages to the event, and perhaps the best analogy to use is the work by William Haddon. William Haddon looked at events that occurred and tried to account for why things happened, because we all know that accidents aren't really, well, all accidents can be avoided. And so Haddon split up the events that occur, such as an accident, into 3 phases. A pre-trauma phase, and this is where the individual, both physically and mentally, can be assessed prior to the incident, so what state were they in? Then there's the trauma phase, the actual event itself, and that'll be the effect of the incident. And then after the event. And it's after the event where they hadn't looked at the effects of an individual and indeed family. And this can be applied to all types of event, not just a traumatic event. But if we relate it to the events leading up to post-traumatic stress, then Watson and Shalev suggests that there's a number of things to think about. These are the characteristics that might make you more predisposed to post-traumatic stress disorder. That you're female, that you are about 40 to 60 years old, you don't cope very well, or you may be within your community an ethnic minority, may have had previous psychiatric problems or experienced prior trauma, may have previous anxiety, being an adult with children, and those of you that are parents, I do agree that sometimes children can be quite traumatic. Being a female with a partner, having an unstable family for support, or indeed being a child where they don't have a proper functional parental relationship and the relationship's dysfunctional. So they're the predisposing factors that might contribute to it to be aware of. But in terms of the event itself, then were they involved in the event or did they see it? I remember significantly driving past a car, should I say, which seemed to be stationary on the inside lane of a motorway, and then looking in my rear view mirror because I just passed a lorry, and then seeing the lorry hitting the car. And I won't forget that because it was quite shocking. I could see it was going to happen. Now, the other thing about the event is relating it to perhaps what other loved ones have experienced, or is it a threat to your life? Witnessing death, it's not nice. Or were you in a state of panic? Following the event, though, there are other things to think about as to what might lead to post-traumatic stress. Not having proper support or having marital problems with your spouse relationship. You may be in a position of losing your home or financial loss, especially if you've been involved in the trauma, or indeed reliving it. Being pestered by the media all the time, or being pestered by police for interviews. Relating it to other family members who have made suffered a similar incident. Or relating it to the probability of it occurring to you. So they're all factors, characteristics that might actually increase your risk of developing post-traumatic stress. So what are the treatment options available? Well, we used to use this approach years ago of suggesting that we had a debrief. So straight after the event, certainly if it was something significant in my department at the time, I'd meet with staff and just quickly talk it through if there's anything anybody wants to ask. In fact, nobody recommends that now in the UK. It's suggested there's absolutely no benefit at all in having a debrief session straight after the event. And it's not really supported. What our national collaboration advice is in terms of evidence, this organisation called NICE, what they do is they suggest a wait and watch approach. Let's see if the person will start developing signs and symptoms. So what happens is that if there's any sign of any symptoms developing, then they'll require follow-up. Now, hypnotherapy has been suggested as a treatment, but certainly medication-wise, which I'll come on to in a minute, that's not really recommended. But they do state in the best evidence is something called psychological first aid. And psychological first aid is being aware that the individual may have been affected and periodically throughout the weeks or months just offering the opportunity to talk about the problem. It's about removing the reminders of that situation that happened, if you can. It is about offering support and then reducing any effects. And sometimes that might also require education for staff. It's not been really tested as a method, though, so evidence-wise, we can't rely upon it. A common method used, certainly from a mental health perspective, is something called cognitive behavioural therapy. And this is like a reprogramming, if you wish, through extensive interviewing. It's more for long-term problems. What about drugs then? Well, drugs shouldn't be routinely offered. It's a quick fix for some doctors, just to give the patient some pills and to go away. All it does is masks the problem. If drug treatment is to be offered, it's to be offered by specialists. Now, the only drug that's licensed in the UK is a drug called paroxetine. Well, there are lots of others used, though. Might use propranolol, it's a beta blocker. You use that short term, but it's not a permanent fix. Use spiridone, that's used in psychiatry, and it may reduce flashbacks. But what they do advocate is not to use drugs of sedation. There's no evidence to support them. However, what about those caring for those that are injured? You. What we've got to think about, I think, is that certainly following a trauma, following, say, a motor vehicle accident, motor vehicle crash, is that we do need to think that care, psychological care, starts at that point. That the paramedics will start talking to the patient about what's happened, but also think about what they say. I don't know whether any of you have ever heard or seen or witnessed this, but when you're semi-conscious, lying on your back, possibly with a collar on, your hearing is very acute. Well, you can't see what's happening in the bed next to you or next to you because you're just looking upwards. And what if you hear a nurse saying, "It doesn't look very good, does it?" Okay, from the patient's perspective, they think it's them. So just take care also about what you say. So, what then about those that look after the injured? Well, it's recognised that some people are affected. I'm not going to say too much. But it is about improving self-awareness for you to look after each other a bit. Okay, now there's a study performed by Warren et al. Who actually looked at surgeons dealing with trauma. Now, there were 133 surgeons surveyed in this piece of work, looking at how they respond to stress, and certainly using different scales, such as a secondary traumatic stress scale, 22% of them did display signs of post-traumatic stress. So it does affect them as well. However, what I think is more remarkable is that 2/3 of all of them showed at least one symptom of traumatic stress. So it does affect everybody. So I think care's got to be taken as to how you recognise that. There's no correlation between the time that the event happened and the level of stress, because we all cope in different ways. Now, from a nursing perspective, the Royal College of Nursing actually says there's been no audit to date upon nurses within the United Kingdom and their risk of developing post-traumatic stress. That's concerning, isn't it, really? Now, many of the nurses offer the view, well, I'm okay, at least I'm not the victim, I'm not the casualty. Could have been worse. It's not me or my family that have been hurt, so why should I be complaining? And that's the attitude, perhaps, that a lot of nurses could take, but that event actually may affect them. And I don't think it's too dissimilar from how it affects the doctors, indeed the surgeons. So employers, I believe, shouldn't assume that because they're not showing any signs of not suffering, that they actually aren't suffering, because they may be. So I think employers should take heed. Now, the Royal College of Nursing suggest that any policies relating to looking at stress need to be reviewed every 6 months. And they suggest, within the UK, that employers must investigate or analyse any traumatic incident. We had there's one locally with ourselves in the UK. There was a minibus went into the back of a stationary lorry which didn't have the correct lighting. The minibus caught fire and 8 children died. The emergency team that was sent out from the hospital, which included many nurses and doctors, basically arrived to find 8 charred dead bodies. And that significantly affected them. In fact, there was one nurse, she was a sister, and she actually left 5 years after the event because she found it still playing on her mind and couldn't cope. She couldn't cope with the sights and the smells of the event. So it's important that employers do offer some form of risk assessment following a big traumatic event. They should have some policy for managing any critical incidents that occur. They should offer training and have clear referral pathways for those that suffer distress. They should also just think about post-traumatic stress disorder procedure and audit it on a regular basis to make sure it meets the needs of their staff. So there's some references that I've added to as well. I just wanted to say one other thing to you. Rhiann Burks has a charity now, and she's still raising funds for post-traumatic stress disorder for nurses and healthcare staff in trying to recognise it to be able to treat it earlier than we currently do. Thanks very much.
Thank you, Mr. Tim. Next, actually the final speaker for the day is Mr. Ramesh Prasad. He is a senior lecturer in Faculty of Nursing and Allied Health Sciences, Open University of Malaysia. Mr. Ramesh has obtained his Masters in Education, Educational Management from University Brunei in December 2007 and Bachelor of Science in Health Studies in March 1997, Certificate in Education for Technical and Vocational Education from University of Huddersfield, UK in July 1992, and Postbasic Certificate in Orthopedic Nursing from College for Postbasic Nursing, Malacca General Hospital, Malaysia in June 1987, and a Certificate in Hospital Assistant Practice from College of Medical Assistants in September 1981. Mr. Ramesh started his career as a medical assistant in the Accident and Emergency Department from September 1981 to March 1983 in Pahang. He continued to work as a medical assistant in the Accidents and Emergency Unit, Pahang, Malaysia, 1983 to 1990. He became a clinical instructor and posted to Accident and Emergency and Orthopedic Disciplines at Seremban General Hospital, Malaysia, where he worked from 1991 to August 1992. So I would like to invite Mr. Ramesh Prasad to talk on the topic Compassion Fatigue among Emergency Healthcare Providers in Management.
Thank you for that. Oh gosh, almost embarrassed now. Okay. Yeah. So I have the distinction of being the last speaker. I know that I don't know what to say. Better I don't say what. Yeah, we'll just see what happens. Right. That's correct. Are you Bowen? Right. Thank you. Thank you for IHS. Thank you for hosting me here. And this is my first trip to Sri Lanka, and well, it's been. I'm very happy to be here. Actually, very happy to meet so many wonderful people, and it's a good place to be. That's what I can say. Okay, I come from Malaysia. I think most of you by now would know where Malaysia is after the MH370 disappearance and Mr. Obama's visit there. It was on the global, media. Okay, we're just south of Thailand, north of Singapore, and a bit on the east of Indonesia, Sumatra. Right? The country, briefly, there's unity in diversity. If you come to Malaysia, it's hard not to find somebody who is like you. I mean, from your country. We have a special link with Sri Lanka. In the early colonial days, it were people from Sri Lanka who the British brought to Malaysia to run the civil service. The people from Sri Lanka were supposed to be educated and people who could administer and who could run the country, and we learned from them. So now probably we will teach you a bit. We will send back the education here through IIHS. we'll repeat the favor. Okay? Yeah. And there are still some people from Sri Lanka there. In fact, our chief Buddhist monk of the country is from Sri Lanka. Okay, if you go to KL, you'll find that. And many more. Right. And we use this tagline, Malaysia truly Asia. You'll find Indians, Chinese, Malays, Portuguese, what have you. Okay, all there. A bit about the healthcare system. We still subscribe to the traditional healthcare system where the government provides the bulk of the healthcare service. So it comes from the government budget, and it caters for the not really wealthy people. I mean the working class. Okay, mainly poor, and although there is a very thriving private healthcare service going now very rapidly, okay, groups as well as singular providers. As far as emergency care is concerned, emergency care is still pre-hospital emergency care. Pre-hospital emergency care is still not very regulated in Malaysia. We have trauma physicians, trauma surgeons, but it is still developing, work in progress. Okay, the pre-hospital emergency care service, there's not much accountability. If you bring a patient to the A&E, I mean whatever you bring, that's okay, receive. Nobody will ask you any questions. Why did you bring the patient in this type of condition? Before this, I was in Brunei actually once, worked there. It seems if you bring if you pass over a patient who has chest pain in Brunei to the external emergency department, and the person does not have oxygen and all that, the AA staff will not let you go. You'll be accountable for that. They audit care. And they are very serious about how you do things. So Malaysia is still, people still get away with things. Okay, because the care providers, it's we have NGOs like St. John's, Red Cross. We have private ambulance services which are run by anybody who has money to convert a van into an ambulance. And of course, there are the universities who have the teaching hospitals. They also provide ambulance services, and the government. So there's a lot of different bodies, and they don't coordinate, and everybody just does what they feel is right. The country facts, parliamentary democracy. We have a king who is elected every 5 years among the different sultans. I mean, each state had a sultan, and they rotate among themselves. We have a prime minister, Dato Sri Najib Tun Razak. Population not very much from Sri Lanka. Sri Lanka is 21 million, I think. So we are about 29 million. Okay. Life expectancy 74, 78. Okay. Ladies have a slightly better lifespan. Okay. We have 14 states, and KL is the largest city. Okay, enough of that. Now, OUM, Open University Malaysia, that's where I work. We are actually about not far, in age-wise with IIHS. Okay, we had this license to operate the university in the year 2000. When Dr. Mahathir was the Prime Minister, he was pushing for IT, multimedia super corridor. I think he invited a lot of people from Silicon Valley, California. Who, he wanted to really develop the country, and he was in a hurry. With the Twin Towers and all, that's the time it came up. Right? And then 1 year after the license, we had our first student intake. Okay? And we focus on working adults. We don't take students who are on full-time study basis. So anybody wishing to come to study in OUM, you need to find a job. You cannot get a student visa. Okay? Talking about people from outside. But you can study from your own country because it's online. A lot of students study from Middle East. A lot of people enroll from other countries, and they study in your own home state. Okay? You just go for exams. Even you don't even have to go to Malaysia for exams. It can be done locally. Okay? And we leverage a lot on ICT. Okay? Our student population, we are actually very proud. One of the biggest in Malaysia now. About 112,000 students have gone through our university. It's quite big. Okay? And we offer about 55 different programs. We are governed by a panel of vice chancellors from public universities. Okay, it's very clever of the government. Okay, when they gave us a license, they made sure that we don't compete with the public universities. Okay, so the heads of the public universities moderate our programs and how we run things. So one way is to keep the cost down. This keeps the cost down. So we don't really money is profits are not really the first criteria. Okay? And we have a lot of international partnerships. Okay, you can see in Sri Lanka we have 2 partners, and as well as in the Middle East, in Hungary, in Vietnam, and Maldives. Okay, we have a partnership. In Africa, growing in Africa now. Okay, and that's a breakdown of some of the programs we offer. About 50% is undergraduate degrees, and about 30% would be postgraduate, okay, and diplomas and all that. Okay. Learning style, self-managed learning. Okay, we don't have full-time lectures. The student, they're working adults. We give them the notes, they go home, they read. And we have online sessions with the students, forums, e-forums and all that. Okay? And of course we organize seminars. Every semester, which is about 4 months per semester, we meet the students about 4 to 5 times. Okay? 4 to 5 times staggered over the 4 months. And then we take it on from there. And that itself is not compulsory. If the student doesn't feel like coming, it's all right. Okay? Because you can always converse, link with the tutor through online forum. Okay? So, and also we don't have a big full-time staff list on our payroll. Okay? We have a big database of potential lecturers, tutors, who are actually drawn from industry. Okay, people from the industry who are experts and all that, who want to, who feel like wanting to contribute to teaching and learning, they come on board. They are appointed. We give them a short crash course on teaching methodology, and then whenever there is a demand for them, we tap their resources. Okay, they become our tutors. Okay, enough for that. Now coming to the main business of the day. The main business for the day, I had actually rephrased my title a bit. Earlier it was Healing the Helper. Healing the Helper. I thought the contents of my topic was not, you cannot heal. You can help. It's not something that you give a pill. It's not an infection that will go off after, because this is a behavioral issue. It will come again. It's something that can happen again and again. So you can only control it. You can only curb it. You cannot really eradicate things. Okay? Let's see how it happens. It's about compassion fatigue among emergency care providers. I think Tim talked about it. Talked about post-traumatic stress disorder just now. There are some related issues on that. Okay? Probably it's about semantics. More sympathetic. Okay, let's see. Introduction. I'm sure all of us have, heard about, studies about stress. Studies about stress as, among the professionals, isn't it? Everybody who works will undergo stress. Is there anybody who says that, after some time of working, we don't feel we don't have any complaints? Or, I think all of us do that, isn't it? We all have our grouches, grudges, and, complaints. Why is it not like this? Why is it not like that? So stress is a common thing. Stress at the workplace is actually not a new issue. It has been debated. It has been studied. It has been, dissected, argued, from every angle. But what I am trying to say today is that, most of the studies, the bulk of the earlier studies, look at stress from the perspective or from an extrinsic perspective, something that causes the person, the worker, to break down, to have stress. Okay? The angle that I am going to talk to you about, is there some weakness, well, for want of a better word, okay? Is there something inside that person itself that makes the person more prone, brings the threshold down, that invites the trouble, the heart pain, the stress, the so-called stress. Is there something that we do as care providers that makes us vulnerable to this, So, is there something we could make ourselves more resilient, more stronger, to withstand this thing? It's a lifelong. We are on the job. It's not that you cannot change your job, but then, we've got to find a way to cope with it, to live with it. Okay. So we have this study, Abendabov and Flannery. They look at nurses. They look at nurses who were showing signs of anxiety and blurring of boundaries. They were nurses, but they were doing things that were, everything else besides nursing. And they said, why was this happening among hospice nurses? And they found that 26% of these people were having a condition called compassion fatigue. Okay? There is a scale. Later on, I'll talk to you about the scale, compassion fatigue scale. And 78%, mind you, were in moderate to high risk category of having this stress. Okay? It's not confined to nurses. It's confined to a lot of other professions which involve helping, which involve caring, which involves, providing support. So let's look at the theoretical perspective. This is actually the focus of my gist of my future studies. Okay, professional nursing practice thrives within the context of a caring and empathic relationship. The empathy is important, isn't it, in nursing? I'm sure nobody will say that empathy, we can become thrifty on empathy. If you say that, then you'll be in trouble with your superiors, right? We all know that the more empathy you give, the better nurse you are, the more caring you are. But mind you, this same empathy can pull you down. Okay? Watson's theory. Watson's theory talks about relationship-based care. Okay? It says that for human caring to happen, a nurse has to forge an empathic relationship with the patient, isn't it? And it's not just, you must convey that feeling of empathy to the patient, to the client. And so there is this bond, and there is trust, and there is more, the relationship becomes more trusting. Okay? So empathy and engagement caring, what is it? Empathic care determines the level of genuine engagement. So it's not just lip service. It's not just, it's not patronizing. As we know, sympathy, isn't it? It's not sympathy, right? By the professional care providers towards the client. Genuine engagement influences outcomes such as quantum of job performance. If you genuinely care, you get happiness and satisfaction from the care by seeing the patient getting discharged, by seeing the patient getting better. Okay, there is genuine satisfaction. Okay, but there is a burden to this caring and empathic engagement. Okay, the state of heightened motivation and proactive drive for quality care provision can falter. It does not remain at the high level all the time. It can come down, isn't it? Because for the patient, probably the patient sees this one beautiful angel, very caring angel, nurse. But that angel has to care for the same care for every other patient, isn't it? For the patient, there is this nurse, but for the nurse, there is the next patient, and the next patient, and the next patient. So can we really sustain that, level of engagement, empathy and this engagement for everyone? Okay? Professional carers begin to feel exasperated, emotionally drained, and show signs of depersonalization. Okay? What is this depersonalization? Sense of detachment. Reflect back. After some time, I remember my days when I was younger. My lecturers, when we were in the clinical areas, when we say bed number 10, that's where the trouble starts. That's one of the signs of depersonalization, isn't it? It's not bed number 10. It's not the diagnosis, the patient with a fracture. No, it's the name of the person, the patient. That's what we were told, that, you must remember the name of the person that you are giving care for, isn't it? That's what individualized care is all about, isn't it? Care planning and all that. It's not that bed number 10. It's not the patient with that fracture neck or femur or something like that. If that situation comes in, depersonalization has begun to set in. Because that's no more a human being. That's a problem now. That's that furniture at that corner, isn't it? That you have to fix, something that you need to fix. So be careful of that. Okay? And this is drawn mainly by chronic frustration. This sense of depersonalization happens because we get frustrated, we get tired. Our idealism is lost. That Florence Nightingale thing probably becomes a bit diminished. Okay? And become pessimistic. We begin to lose the belief that this patient will get well, and we all this negativity starts affecting. The professional quality of life begins to suffer. Okay, and who are particularly vulnerable? Doctors, nurses, paramedics, psychologists, mind you. Okay, social workers, teachers, clergymen, counselors, policemen, everybody. Okay, everybody who needs to give empathy care, okay, including academics like us. Okay. So what is this professional quality of life we're talking about? Just put it in context. A feelings-induced drive, okay, to volunteer active involvement, okay, and accomplishment at the workplace. So if you have this, that the idealism is still there. But you begin to lose on it, then that's where trouble is going to set in. Okay? It is the natural consequence of helping on the professional quality of workers. So this term, 2010, he talked about two poles or two paradigms. Okay? Compassion satisfaction or compassion fatigue. And this is his framework. Although I have put it up here, I actually challenged this framework by him. Okay? A person cannot have continuously, compassion, satisfaction all the time, perpetually. There will come a time when you will get fatigued. We're only human, isn't it? There will come a time when we will get fatigued, and we will not be fatigued all the time. There will be moments when the spark comes back. We get a bit rejuvenated, and it's not an end in itself. Okay, it's a shifting paradigm. Okay, and burnout is not actually as a cause of compassion fatigue. It can happen in itself. Later we'll talk about burnout, and also I'll show you the difference between burnout and compassion fatigue. Okay, there are some subtle differences. Okay. So compassion satisfaction is a positive aspect of a professional's quality of life. These are the times where you are beginning to give care. I remember the first time I did CPR and the patient had this sinus rhythm, return of rhythm. I was so elated. Finally, I think I can do it. But after some time, it becomes a bit challenging to maintain that level of that celebration, isn't it? So he provides affirmative feelings of goodness and well-being among professional care providers in the act of having helped someone in need. Okay, And the other side, compassion fatigue, this is the negative aspect of a professional quality of life. Okay? And it was first described by a nurse, Miss Johnson. She coined the word compassion fatigue in 1992 as a unique form of burnout that emotionally affected nurses caring for mental patients. Okay? But he just stopped there. She just stopped there. It was Figley, the next person, who associated compassion and empathy. Okay? That is actually the important criteria for maintaining the drive, can actually be the start of the downfall. Over empathy can actually cause more trouble. Okay? She said that compassion, empathy that drives the impetus for kindness, caring, and genuine concern action by the professional, but insidiously it also will help the care provider in the long run. Okay? This is very serious, isn't it? Now we are challenging the status quo, it seems. And we are talking about empathy. So far, has anybody regulated empathy? How much empathy we should give? What dose? How much is enough? This is something different. This is now something challenging the status quo. Okay. Typical symptoms of compassion fatigue. We lifted it from a book. Avoidance or dread for working with certain types of cases. Okay, which bring that negative, images, which you don't like, you want to avoid. Okay, reduced ability to feel empathy towards clients, depersonalization. Okay, feeling frequent sick days. Okay, starting to have sick days. General lack of joyfulness. Okay, physical symptoms like headaches, frequent headaches, digestive problems, diarrhea, constipation, stomach upset, muscle tension, and all that. Okay, and emotional mood swings, okay, restlessness, irritability, oversensitivity, anxiety, and things like that. Okay? Loss of objectivity, okay? Poor concentration, focus, and judgment. And let's look at another one, burnout. Okay, burnout can be a bit different from compassion fatigue. Okay, this is something which is more acute. Okay, a syndrome of emotional exhaustion, depersonalization, and reduced personal accomplishment among individuals as a result of chronic work stress, not necessarily empathy. It can be the wrong choice of career, something being in the wrong job. Okay, employees most likely to experience burnout early in their career cycle, with the highest risk occurring the first years of employment. Okay, being in the wrong job. Maybe after the honeymoon period is over. Okay. Okay. Burnout leads to negative outcomes such as low productivity, lack of concentration, poor time management, difficulty to understand new procedures, lack of teamwork, and so on and so forth. Nursing staff who experience burnout are likely to leave the profession early in their careers. Okay? Whereas compassion fatigue is different. The compassion fatigue, the nurse will feel guilty. Why is she not caring enough now? She used to care. He used to care. The empathy. Okay, why is the empathy now? There's beginning to be self-doubt in that person. There's a bit of difference. So we look at some comparison between burnout and compassion fatigue. In burnout, we'll have anger and frustration. Okay, you don't feel that you fit into that role anymore. Okay, there's fatigue, chronic fatigue. Okay, negative reactions towards others. Always negative, always not happy. Cynicism, general negativity, okay, withdrawal, relationship disturbance, okay, personal traits, certain personality traits. Type A personality maybe, okay, hyper, a person who is really, on the edge, probably. Work-related attributes, okay, so all these can be trigger factors. Whereas compassion fatigue, there is feelings of sadness and grief. Okay, because this person is a person who empathizes a lot. So they take ownership of that pain of the patient. They feel the pain by extension. Okay, so but they are not able to let go. not able to switch off. Surely they cannot switch off because it was genuine concern, isn't it? So it's difficult to let go. Okay, if you truly empathize. Okay? Nightmares, social avoidance. Okay, you like to be loners. Okay, addiction proneness. Okay. Increase psychological arousal. Okay, feelings of witness guilt. Okay, detachment, decreased intimacy. And then the trigger factors can be empathy and emotional energy, draining of that. Prolonged repeated exposure to trauma and grieving incidents and stressful response to trauma incidents. I did a pilot study actually. I lifted this scale. It's in my reference by STEM 2010. And I tried to see if it actually, if the results would apply to my students back home in Malaysia. Okay, I teach a group of nurses who go on this trauma posting. Okay, trauma posting for about 2 weeks. Okay, 2 weeks, and those who had experience providing care to this trauma and grieving and all that, I gave this question to them, number 50 of them, and of course it's not a good sample because these people, one thing is that they knew that they were there for a short time. They were not really obliged to be an ideal, emergency care provider. They knew they were there just to, get the marks and go back. But then, did it affect them? Yes, surely you see that. Okay, you can see that line. I don't know how to show here, but you can see it here. The green one is compassion fatigue, and blue is compassion satisfaction. You see, when there is decrease in the blue line, there is an increase. There is a spike in the green graph, isn't it? Opposite. So it shows that this scale actually, there is some impact there. Okay, there is some impact. Of course, my plan in future is to conduct a study among the various emergency healthcare providers. Okay, and compare those probably in the St. John's and Red Cross who are supposed to be altruistic. These are volunteers, isn't it? They should have an element of altruism in them. So does compassion fatigue get to them? And compare it with emergency healthcare providers who are in the government service, who are professionals, who have been appointed on the job, and make a comparative study and find out where is the middle ground, where is the problem there. Okay, so there is an urgency to address these issues with professional quality of life. Okay, there are compelling reasons for the necessity to address this problem. Okay, there are a lot of emotional costs and dire consequences if we just let nurses be like this. Okay, one thing that deteriorating quality of care can erode into the nurses' obligation to provide personalized and quality care to their clients, and by extension can also affect their own emotional well-being, isn't it? And lead to a lot of adverse events, a lot of accidents, a lot of mistakes can happen. Okay? And the stressful environment of the emergency healthcare service can also contribute significantly to threaten the well-being and staff morale. Okay, if it's left unchecked. Okay, and nurturing compassion satisfaction can help to avoid burnout, high stakes of staff turnover, and loss of experienced staff from the profession. Okay? So in conclusion, creating an ambience that enhances compassion satisfaction and it curbs compassion fatigue is a win-win proposition for all, the nurse, the client, as well as the management. So in summary, job satisfaction is a common idealistic aspiration among workers and management alike. Keeping a cordial work environment, especially away from fatigue and burnout, helps to increase productivity and minimizes injury. promoting an atmosphere that nurtures this compassion satisfaction brings many potential benefits to the healthcare provider, nurse, and profession. And it's not the duty of one stakeholder alone. It's everybody. It's a collaborative effort. Okay, by the nurse, by the care provider, by the management, and other stakeholders as well. Okay? And these are my references. Okay. Any questions? Anybody? Actually, the future direction of the study will be to study on empathy. Okay? Because we all talk about empathy being good. But now we find evidence that empathy being good also hurts. Yes, sir. Please. Yeah. Yeah. Yes. Mm. Yeah. 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 I think that's a very, very, sharp and point on comment. I mean, people going into the profession. I mean, if we really love the profession, why do we look forward to get promoted and get out, and go into teaching and go into, earning more money or doing other things, rather than doing the things that we so love to do in the first place when we joined? Where is that the love lost, isn't it? Yes, sir. Please. Yeah. Mm. Yeah. Mm. Right. Yes. Ah. Yes. Yes. Mm. Mm. Yes. Switch off. Mm. Yeah. Mm. Yeah. Yeah. Will rejuvenate. Any comment? I think the jury is out there, isn't it? Yes. Yes. Mm. Mm. Yeah. Ah. Mm. 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 Yeah. 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 Mm. You've got the equation right there. That work balance, social balance. I mean, in a way, yes. If you love yourself that much, and if you have a strong mind to switch off, probably that will be the ideal formula. But we're talking about this professional, the professional who is this true blue, married to the job type of person who, I mean, people in the helping professions. If you want to say empathy means feeling the pain of that client. I mean, if you really genuinely feel, can you switch off from that? I mean, if you really think about it, if you go home, you'll be still calling, hey, what happened to that, that person that isn't it? But if you do a job, yes. I mean, if it's 8 to 5 and 5 days a week, well, I finished my job for the period. I'm entitled for my remuneration, enough. But professional? Professional being responsible for the outcome, not just doing your manual. Isn't it? Professional is not manual. It's being responsible for the outcome. Isn't it? Yeah, it's a lot of things to think about, isn't it? But yeah, maybe that you also must love yourself. Probably it's like the candle. Don't be like a candle. Don't burn yourself to light the world. Probably you need to be like the sun. Yeah, you rise and you you give warmth and you also thrive. And come again tomorrow. Rise again tomorrow. Yeah, it's time to stop being a candle. Yes, anything else? Any other comment? From the nurses, maybe? Yes. Mm. Mm. Burnout. Mm. 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 Yes. Yeah. I think that's a very good observation. Like I said, there are a lot of studies on the extrinsic factors, the outside factors that induce stress in the person. But very few talk about that person's, how do you, scheme yourself, set yourself up to be, to burn out, to be fatigued. I mean, like what Dr. Leonard said, if you think that you are worried about going home and doing the work, don't get married. Don't get married. Isn't it? You think that, so choose, you want to work or you want to get married? Because if you cannot handle both, then choose the one that you love more. I know it's an extreme thing. It's an extreme, yeah. Yeah. To think about, yeah. Yes, 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 yes. Yeah. Okay. Thank you very much. Thank you for listening.
Thank you, Mr. Ramesh. So we have come to the end of the conference by Inquiry 2014. It was a 2 days conference. So before we wind up for the day, it's time for us to offer a few tokens of appreciation. I would like to invite Dr. Kisri Edrisinha to the stage. Dear speakers, thank you very much for coming on these 2 days and sharing your knowledge and experiences with us and doing wonderful presentations. Not only wonderful, I should say interesting. Very interesting presentations. Thank you very much. We really appreciate your participation. Dr. Nihal De Silva, please accept the token of appreciation from IIHS. Thank you very much, sir. Dr. Leonard Ranasinghe, please accept the token of appreciation from IIHS. Thank you very much for all your contributions, sir. Mr. Tim Moss, please accept the token of appreciation from IIHS. Thank you very much for all your contributions, sir. Thank you, Dr. Kitsuri and Mr. Shah. I would like to invite Dr. Nihal De Silva to the stage. And Ms. Nishania as well. Mr. Ramesh Prasad, please accept the token of appreciation from IIHS. Thank you very much for your participation and all your contributions, sir. Dr. Kitsuri Edrisinha, please accept the token of appreciation for all your hard work and initiating the conference. And also Mr. Amila, Mr. Karindu, Ms. Surani, Ms. Stephanie, Ms. Miriam, Dr. Nishan, Dr. George, and the rest of the IIHS staff, please. I cannot see the other faces. Dr. Nihal, please remain on stage. And also we cannot forget our guests for the day, the members of the Maldivian Nursing Council, Ms. Husna Ibrahim, Ms. Fatima Shafin, and Ms. Fatima Khalil. Please accept tokens of appreciation from IIHS. Thank you very much for coming, madam.
last few minutes made my job much easier because I think Maisha and Dr. Kitsurian, while before me, did all the thanking. But once again, I'd like to place on record thank you on behalf of International Institute of Health Sciences and Green Healthcare Private Limited to our eminent panel of speakers, Dr. Leonard Ranasinghe, Mr. Tim Morse, Dr. Harand Bogazan, Dr. Gamini Gunatilaka, and Dr. Kitsuri wanted me to specially thank Dr. Gamini Gunatilaka because he had accidentally omitted to mention him in his speech earlier. He's a wonderful resource, I think, in his presentations. You realize what an impact he's made on trauma and emergency in Sri Lanka. Mr. Ramesh Prasad, thank you very much, sir. Dr. Adrian Mirenia, thank you. Dr. Savita, she's not here, she's already left. Ms. Renee Fraser, again not here with us today. And Dr. Nihal De Silva and Dr. Kitsuri